Hello and welcome to another blog summary video. I have taken the opportunity over the last month to revamp the old Chemotherapy Induced Peripheral Neuropathy blog, Top 4 Things You Should Know, and try to include updated science and kind of more detail in the protocol and think of all the common questions that I've been getting asked in clinic. So this is really a response to some of the demand that I've been getting in clinic. It's an updated version, and it is everything you need to know about chemotherapy-induced peripheral neuropathies, or at least the most important parts that might help you to make decisions around it. So this blog really includes rehab tools for chemotherapy-induced peripheral neuropathies from the standpoint of prevention and management. So we know that neuropathies are very common within the cancer population. There can be a lot of different types of neuropathies, and this blog does go into some detail to kind of explain that we want to make sure that the diagnosis is accurate and that the chemotherapy-induced peripheral neuropathies are indeed CIPN, that's the acronym, and not more of a plexopathy or a neuropathy secondary to radiation, etc. So we definitely want to get that accurate diagnosis. So the blog does start off with kind of an overview of what is peripheral in the nervous system. Well, we know that all components outside of the brain and spinal cord are termed peripheral. Okay, so everything that branches out is peripheral. So it's a very general term, peripheral neuropathies, and that they need to be induced by chemotherapy to be diagnosed as CIPN. Sometimes there is areas of branching nerves that can kind of get pressed or stuck in wounds or radiated that can cause symptoms that travel down the arm or into the hands. And so that can sometimes be misdiagnosed as CIPN. So it's important to get an accurate diagnosis, and this is definitely something that a cancer physio can offer. So we know that chemotherapy-induced peripheral neuropathies, most people think about it. They think about, okay, tingling in my hands and feet, hands and glove kind of patterning. This is absolutely true, but peripheral neuropathies induced by chemo can actually occur elsewhere too. So you can actually observe changes in your bladder and bowel or digestion during chemo, that kind of oscillating, bowel upset, constipation, and back and forth, and diarrhea, symptoms like that are actually termed chemotherapy-induced peripheral neuropathies. In addition, after chemo, sometimes there is some change in the vestibular nerve. Patients feel a little unsteady, their gaze stability might kind of be off, they're a bit dizzy, they feel like they're on a boat. Those symptoms as well are actually classified under the umbrella of chemotherapy-induced peripheral neuropathies. It would be more of a vestibular neuropathy. So if any of these symptoms of kind of, tingling in the hands and feet, dizziness, or bowel upset are occurring during chemotherapy, it's probably worth getting an assessment. And this blog also helps you understand tools to make decisions around that as to kind of when to notify your medical oncologist. This blog also goes into detail to kind of describe the anatomy of the nervous system, but also how nerves get injured, because essentially chemotherapy is injuring nerves. And so does surgery, and so can radiation. So it's important to understand that there are 3 classifications of nerve injury. They can be cut, they can be pressed, and they can be stretched. And depending on the type of injury, that heavily determines the nerve's prognosis and the possibility of it coming back to normal. So it's important to understand a little bit of the bigger context of treatment to understand what nerves might have been injured and what kind of injury might they have had. So this goes a little bit into a little deep, dark place, a little bit of a rabbit hole here of explaining the different scientific terms for these nerve injuries. We won't go too much into that unless you're really interested, but sometimes we can see a full cut. That's often with surgery. Sometimes that can lead to a nerve palsy. So you can develop conditions like spinal accessory nerve palsy, sometimes due to a radical neck dissection. Sometimes with breast cancer, post-surgery, specific surgeries can lead to long thoracic nerve palsy. This is when the nerve actually might not come back because it has experienced significant damage. Most of the time in breast and head and neck cancer, we see more neuropraxia and axonomatesis. This is more the idea that nerves have kind of been stretched and moved aside during surgery, and then swelling comes in and maybe presses on them a little bit. So they're just kind of jangly for a while, and they might be producing symptoms. That's more of what we see. But truly, the surgical report is where you're really going to understand kind of what happened coupled with a physiotherapy assessment, a neuropathy assessment, we can really gauge, okay, what happened and what can we expect? What's the prognosis? So it's important. And I've generally heard neurologists say it can take up to 2 years for that new baseline to be established, where you understand that, okay, that's where my nerves have come back to, and that's their new normal. They're at full capacity. So we know that an assessment and an effective diagnosis are really important in then obtaining a very effective rehab plan. And that is how we can start to use some of the tools in the rehab plan. The blog then goes into detail as to why do chemotherapy-induced peripheral neuropathies, otherwise known as CIPN, we'll keep it short for now, why do they occur? This is going into a bit of detail about the kind of biology and cellular physiology side of things. But there are different classes of chemos, in a kind of bigger picture, and these different classes, taxanes, platinums, vinca alkaloids, and targeted therapies, do tend to have different macro effects. We tend to see from some studies that were done in the last kind of decade that oxyplatin and paclitaxel were some of the most prominent in causing insult to the peripheral system. Okay? Symptoms associated with oxyplatin typically presented in the upper extremities. It kind of had a cumulative effect, intensifying with each round of chemo. Paclitaxel, otherwise known as Taxol, often first presents kind of as pain and typically impacts the feet and the lower extremities. So we see these kind of different indicators. So if we know these kind of presentations and we know your treatment history, we can be watching for these things and catching them as they start. Vinca alkaloids is kind of the class of medication of chemotherapies such as cisplatin that tend to have more of an effect on the vestibular nerve. So this is where we're watching for vertigo and dizziness and instability and things like that. So we won't go into the cellular physiology of kind of how the chemo affects the peripheral system unless you really want to. It's there. Feel free to take a deep dive. We know that the insult to the nerves typically happens on the sensory nerves, but it can impact other nerves too. So that's where you can kind of click on this drop-down accordion here in the blog, and you can see some of the symptoms that you might experience associated with injury to different types of nerves. Sometimes weakness or shakiness, that's more of a motor nerve. Sensory is what we see most of the time. So that would be presenting, CIPN would be presenting as altered sensation of pain, numbness or hypersensitivity, kind of trunk or hip pain. That's about 3 days post-chemotherapy injection. Altered perceptions of temperature, vibration or touch, electrical sensations, burning sensations, shooting sensations, numbness, tingling, or itchiness. So lots of little ways of just describing different altered sensation. That's primarily the nerve type that gets impacted the most. But once again, we know that peripheral neuropathies can also occur in the autonomic system. This is more where we see sometimes that bladder and bowel or vestibular system. So you can see dizziness, bladder incontinence, blood pressure changes, constipation, or diarrhea. And I don't think that's classified enough sometimes as an induced peripheral neuropathy, but those symptoms are very much under that diagnosis. And once again, once you have an accurate diagnosis, you can have a really effective rehab plan, and that's why diagnoses matter. So let's talk tools. It's really important that you understand that there are tools that you can use to prevent and manage CIPN. One of the first tools is to speak up. So some pre-existing conditions do put you at a higher risk. As an example, pre-existing neuropathies, obesity, diabetes, previous lymph node removal. These things matter in kind of putting you into a risk profile of whether or not the CIPN could occur. So discuss your health history in detail. Another thing to consider is that if you do have any kind of baseline neuropathy, maybe consider a neuropathy assessment with your cancer physio prior to undergoing treatment so that changes can be tracked, especially if your baseline is already kind of different than a fully functional baseline. So that's just something to consider. If you are starting to have symptoms in your hands or your feet, speak up right away. It's important to speak up because the medical oncologist can talk to you about the risk profile associated with your health history, your cancer type, your chemotherapy type, and discuss whether or not a dose delay or kind of a reduction in dose is an option. Chemotherapy-induced peripheral neuropathies sometimes are irreversible and can occur and be quite severe and over the long term in certain scenarios. So it is really important to speak up if you're having symptoms right away and discuss that with your medical oncologist. One of the recent systematic reviews really did state that dose delay or reduction in chemo was one of the most effective interventions in chemotherapy-induced peripheral neuropathy prevention and management. So it is something I think that patients need to know. Yes, you're in survival mode, but feel free to speak up. The second tool is to optimize your safety. This is in terms more, I would say, of management instead of prevention. But there's a whole list of little hacks and tools here, like using oven mitts when handling hot plates, checking the temperature of your hot water tank, making sure that you have some night lights if you're feeling a little unsteady. If you can't feel the gas pedal and brake through your shoe, consider a cancer physiotherapy assessment to assess if you're safe to drive. Things like when you're doing the dishes, wear rubber gloves to provide better grip and protect your hands from temperature changes and cuts. Sometimes there isn't that ability to sense the temperature changes acutely. So these are just a few safety measures to take if you are experiencing CIPN. The third tool is one that I'm pretty excited about. I think that there's been some neat traction kind of developing with this tool, even in the mainstream population for a variety of reasons. And now the literature and the research is starting to pick up a little bit, and I think it's really cool to catch that wave. So the American Society of Clinical Oncology reviewed the 2020 guidelines for the management and prevention of CIPN. They looked at a systematic review of 48 RCTs. So this is a pretty kind of reliable and good way of looking at science. And there wasn't really any intervention, micronutrient supplement, drug or non-drug, that was deemed effective aside from Cymbalta or diloxetine as a form of pain management associated with having CIPN. So I kind of liked looking a little bit at some of the drug-free interventions that were highlighted as just needing more science, kind of inconclusive, especially the drug-free interventions that are low risk. And one of them is cryotherapy or cold therapy. So digging into that a little bit more, you can see that the Danish investigators kind of started in 2013 with forms of cryotherapy such as frozen mitts when patients were having infusions of docetaxel. And their neuropathies were supposedly kind of reduced by approximately 50%. Those studies then kind of spiraled into more studies and a randomized control trial of 180 patients treated with oxyplatin and docetaxel were also given these kind of frozen mitts. And this study too showed improvements in quality of life and reduction in neuropathy-related symptoms. And what I found really interesting is that now currently at the BC Cancer Agency, depending on the cancer and chemotherapy type, some patients are actually being offered these frozen mitts. So I think that that's really cool. It's a low-risk intervention. It's a relatively accessible and cheap intervention. So I want to roll with that a little bit and give people the accessibility to do this safely. So I'm expanding a little bit from mitts to the concept of cold therapy, and that is not the same thing. However, both induce a similar physiological reaction. Whether I have a cold mitt on, or I go into cold water, or I expose myself to cold, blood is going to shunt out of my hands into my core. So it's a very similar physiological reaction. So for that, we're going to keep it really big, accessible, and open. Research has really started to show that cold therapy or cold exposure activates brown fat, which has a metabolic boosting effect. Repeated cold exposure over periods of time can actually have an anti-inflammatory effect, impacting levels of interleukin-6, which is a pro-inflammatory cytokine that can contribute to chronic inflammation. We also know that cold exposure creates a huge dopamine drop of about 200 to 300% increase. Basically, it makes you feel good, makes you feel alert, and it can help you feel motivated. This is why I highlighted cold exposure in my Managing Hormone Therapy blog. You can see that other blog summary video because hormone therapy can often lead to feeling slightly flatlined. So cold therapy is a great intervention for that. So the important thing about cold therapy is that it's accessible but personalized to you. So if you're curious about this tool, I do think it's important to consider certain factors and have a little bit of an assessment done. because there is sometimes certain measures that need to be taken. And I hear stories often of people kind of jumping off of a dock and then racing out. Unfortunately, I would say that that's not very effective, nor is it safe. And so we really do want to kind of provide you with the ways to approach this safely. So in this blog, I really just called cold exposure anything that makes you cold and uncomfortable. It could be a cold bath, a cold shower, entering into a cold body of water, neck down. It could be the use of cryotherapy equipment. It could even be a cold shower. Although a cold shower is not considered cold exposure in the literature because your body temperature is not always cold in all areas, a little bit more complicated to measure, doesn't matter, let's include it. Anyone who's taken a cold shower will testify there is some stimulation, your hands can still get cold. So we're going to include all forms of cold exposure here to keep it open and accessible to all. I'm even going to say that sometimes patients can wear little booties or gloves if they're starting out and they're finding that there's just a little too much discomfort. There are ways to make this accessible over time. So we are kind of unpacking this idea of using cold exposures to prevent, but also to manage chemotherapy-induced neuropathy. So this is really looking at doing this practice maybe while undergoing chemotherapy or leading to. And the goal of cold exposure is really to focus on your breathing rate, aim to slow it down, and breathe diaphragmatically. So you need to train yourself to be aware of your breathing before you do the exposure. Ways to do this would be maybe starting with cooler temperatures and slowly changing the temperature to be more cold over time, over a span of a couple of weeks. Entering into the cold water or cold exposure slowly, allowing your system to notice and your breathing rate to adapt. These are kind of some examples of ways to make it a little bit more safe and effective. The goal is actually to notice the cold exposure become more manageable, to have almost a bit of a state of calm. That can take a few minutes for that panic and that breathing to slow down, but that's ultimately a representation of a lot of physiological response happening in your body that's really beneficial. So we kind of want to think about doing this in a way that's effective and not just kind of rushing into it and panicking and getting out. So the blog really breaks down a bit of a protocol and gives you a few tips on how to do that. So the protocol that this includes for chemotherapy-induced peripheral neuropathy prevention and management is, when possible, the cold exposure should be from the neck down. If you can't do that, that's okay. It should be about 11 minutes total per week, random number, but that's what the literature's been focusing on. I state that each exposure should be around 3 minutes in length, allowing you to achieve a little bit of calm. And the temperature should be slightly uncomfortable, but you'd like to escape it, bearing in mind that you can decrease that temperature over time, starting with a little bit more comfortable temperatures, focusing on your breathing, training your breathing, and then practicing over time. The last rehab tool here, of course, is exercise as medicine. Can't talk enough about this. You know that this is my passion, big part of everything that I support and offer. There is, however, safe guidelines associated with exercising with cancer, and I've highlighted those again on the blog, just for you to understand throughout the different phases of chemo. Sometimes there are periods that are called nadir, where your blood cell count and various other measurements are low, and you might not benefit from pushing yourself to exercise. You might not have the energy to exercise, and these are ways to watch for those indicators and just give yourself permission to rest during those days. There is some exciting research being done in this area, although the 2020 guidelines also did not include exercise as an intervention. They highlighted it needed more science. Well, more science is happening. So we're really seeing that chemotherapy is often riddled with fatigue and can be also causing things like pain. And we know that generally there's some neat studies happening, over 350 patients, that did have slightly less neuropathy symptoms when undergoing a home exercise program. We also know through the research of Dr. Wendy Suzuki that exercise can increase neural energy, which means it can actually affect memory and attention and learning. So, if you're trying to promote nerve health and prevent nerve damage, it's a bit of an extrapolation, but I would say it wouldn't be a bad thing to increase your nerve energy or your neural energy through exercise when undergoing something that does and potentially can affect your nerve health, such as chemotherapy. So exercise may help manage the side effects of CIPN and lower its risk, but I also believe this research is going to get stronger and stronger. So once again, by having a good diagnosis and a personalized rehab plan, you can utilize the tools that are right for you. And hopefully, with those tools, comes some curiosity, and with curiosity comes openness, and hopefully with openness comes some possibility that you're able to manage your symptoms a little bit better and even prevent some symptoms from onsetting entirely. Thank you for your time. As always, thank you for your interest in science and rehab.